Okay, so Bismillahirrahmanirrahim. So it's very thrilling now to talk and open this virtual webinar. It's one of the successful webinar that has been done by the Saudi Epilepsy Society meeting. So it's my pleasure to introduce our first speakers for the webinar of epilepsies and vaccine. This idea came through our talk within the Saudi Epilepsy Societies to have a series of webinars to talk about various things related to epilepsies or related to the current issues. And obviously the thing with COVID-19 and vaccinations and whether it's related to other diseases or not is becoming one of the hot topic here. So we try to arrange something to give us enough information about the vaccines in general, and then whether it's related to epilepsies. So our first speaker here was actually my first pick for this talk is Dr. Lamia Jad. She's a colleague. She's a senior epileptologist in King Fahd Medical City. She is a person whom I learned a lot when I joined King Fahd Medical City. She's always a good speaker. She always give a great talk about various topics. So when I asked her to present this topic, she said, this is a lot of history for vaccines and epilepsy. But we'll take it from history perspectives and epilepsies related to vaccines. So it's my pleasure to introduce Dr. Lamia Jad to talk about vaccine and seizure and epilepsies. So all yours, Dr. Lamia.
Okay, thank you very much, Dr. Majid. Assalamu alaikum, everybody. Good evening, good morning, good day to people in various time zones. And a warm and safe welcome to the Saudi Epilepsy Society webinar. I would like to thank Dr. Majid and the SES for inviting me to speak today on vaccinations and their impact on epilepsy. So our learning objectives today, or for this topic, we'll find out what are vaccine-proximate seizures, the risk for vaccine-proximate febrile seizures, the risk for afebrile seizures and status epilepticus. The question is, the answer to the question, do vaccinations cause epilepsy? How to manage future vaccinations in children with vaccinate or vaccine-proximate febrile seizures, how to manage future vaccinations in children with epilepsy and epileptic encephalopathy, and also to see if there's anything out about COVID-19 vaccine and epilepsy. So vaccination over time has been quite a true success story. Immunization programs are highly effective public health interventions, and worldwide, vaccines have prevented more than 20 life-threatening diseases. Immunization prevents 2 to 3 million deaths per year from communicable diseases. However, still 20 million children are not vaccinated and underdeveloped in developing countries. In the developed world, however, there is increasing concern about the risk of adverse events following immunization, which is why some families and health caregivers are reluctant to give vaccinations. So what is a vaccine-proximate seizure? These are seizures occurring within 14 days of vaccine. They can be febrile, afebrile, or can present as a status epilepticus. Just to review what febrile seizures are.
The lower public tolerance for the risk means that a greater effort. So,
okay. So we'll just review what febrile seizures are just so we have an idea. So mainly we want to remember this percentage, that they can occur in 2 to 5% of children, which means 2 to 5 in 100 children aged between 6 months and 6 years. And they occur between the age of 12 months to 30 months in 50% of children. Accompanied by a fever without CNS infection. They can be simple or complex. You don't require to do any diagnostic testing except to determine why there is fever. In children with complex seizures, depending on your examination, further evaluation is required. And with seizures lasting more than 5 minutes, just as any status, this should be aborted with a benzodiazepines first line. And febrile seizures are not associated with any increased long-term mortality or negative effect on future academic progress, intellect, or behavior if they occur in a normal child. Now, following vaccination, the timing of febrile seizures coincides with the peak inflammatory response, and this depends on whether the vaccine is an inactivated vaccine or live attenuated. Inactivated vaccine stimulate or prompt a peak inflammatory response within 0 to 48 hours, and these vaccines are such as diphtheria, tetanus, and pertussis, or the trivalent influenza vaccine. Live attenuated vaccines, however, such as the MMR, the MMRV, and Varicella, here the risk of febrile seizure is delayed until 5 to 14 days, which is after the attenuated virus has reached sufficient levels in the bloodstream to be detected by the immune system. This is our immunization schedule here in Saudi Arabia, and this is the ages where our children have vaccines, mostly within the first 6 months of life. The WHO recommends 2-dose measles-containing vaccine, with the first dose at 9 months of age in high-risk countries and at 12 months when the risk is low. And the fever after a measles-containing vaccine is associated with a higher antibody response and higher protection against measles. And this occurs the older the child is. Also, there is a genetic component. A Danish study found 2 genetic loci associated with MMR vaccine-related febrile seizures. Older children are at higher risk for getting fever and therefore febrile seizures. However, if you look at the percentage or the risk, absolute risk, it's 4 in 10,000 children, or 1 in 2,500 children who get their first MMR and varicella vaccines as separate shots at 12, 1 year to 2 years, that develop a febrile seizure during the 7 to 10 days following vaccination. So if you compare that with the 2 to 5 in 100, it is a smaller risk. In children less than 7 years of age, there's a very small risk of febrile seizures following MMR vaccination in the 6 to 14 days after, and this happens in around 1 in 3,000 to 4,000 children. If you look at the MMRV vaccine, which is the combination vaccine, where varicella is added to the MMR in combination. We don't have this vaccine. We give our varicella here in the kingdom alone. But the risk of febrile seizures in 1 to 2 year olds depends on whether the MMRV is the first dose of measles-containing vaccine. So if it is the first dose of measles-containing vaccine, then the febrile seizure risk is higher. And the risk is an additional febrile seizure per 2,000 or 2,300 doses given. So that's in addition to the MMR risk, another. So it's 2 in 2,300 doses given compared to the MMR within the 7th to 10th day following vaccination. There is no increased risk of febrile seizure if MMRV is given as a second dose at 18 months and older. There is no risk of febrile seizure if the MMRV or the MMR and varicella is given separately in children 4 to 6 years. And there's no risk of febrile seizure if the varicella vaccine is given separately. So the MMR and the varicella can be given at the same day, but as different vaccines, and not in combination. Okay. So this is just a study that looked at the MMRV and MMR separate plus the varicella vaccines. And you can see that definitely the MMRV does have a higher risk of seizures per 100,000 doses. Okay. So now we go to pertussis vaccine. Currently we're using acellular pertussis. Prior we were using whole cell pertussis vaccines. These were more reactogenic and were more likely to cause fever and seizures. The difference is around, it was 7 to 9 seizures per 100,000 with the whole cell pertussis vaccine versus less than 4 per 100,000 in the acellular pertussis vaccine. So a large population-based Danish study identified a small risk of febrile seizures on the day of vaccination for the first and second doses of DTPA, only at 3 and 5 months of age, which is the first 2 vaccinations. And this was less than 1 febrile seizure per 28,000 vaccinations, so certainly much, much less than the 2 to 5% within the normal population, within the general population. There was no overall increased risk of febrile seizure within 0 to 7 days of vaccination across the 3 primary doses. And there was no increased risk of recurrent febrile seizures or subsequent epilepsy in children whose first febrile seizure occurred within 0 to 7 days of vaccination. Other studies reported no added risk of febrile seizure on the day 0 to 3 following DTPA. So what are the implications of not vaccinating? In Sweden, the pertussis immunization was held for 2 years, and over 20,000 children were hospitalized with pertussis. 4% suffered neurological complications, and there were 3 deaths. Complications due to the MMR vaccination and compared with measles infection, with the MMR vaccine, 300 children, less than 5 among 1 million children will have febrile seizures compared to 10,000 children. With regards to subacute sclerosing encephalitis, with the vaccine, none through history has gotten it. However, with the measles infection, 10 per 1 million children will develop SSPE. And with regards to encephalitis, the reports have quite been uncertain. However, certainly with measles infection, 2,000 children among 1 million children less than 5 years of age will develop encephalitis. So in a species study of children 6 months to 2 years, a small increased risk for febrile seizures in the 24 hours following inactivated influenza vaccine, if given at the same time as the pneumococcal 13-valent conjugate vaccine, or DTPA, developed febrile seizures. The flu shot was not associated with an increased risk of febrile seizures when it was given on a different day from the other 2 vaccinations. And the risk of seizures with any combination of these vaccines is small, at most 30 febrile seizures in 100,000 children vaccinated. Again, much less than the 2 to 5% in the general population. So the CDC advises to continue vaccination of children according to the vaccination schedule, which allows for flu, pneumococcal, and DTaP vaccinations to be given during the same doctor's visit on the same day. So just a review. So with live attenuated vaccinations, the MMR risk is 1 febrile seizures per 1,000 to 3,000 vaccinations. The MMRV, 1 additional per 2,000 MMR vaccinations when compared with the MMR and Varicella given separately. And there's no increased risk if administered as the second dose. With DTPA, there's no increased risk. With trivalent flu vaccine, flu vaccine is usually given or is usually manufactured twice a year, depending on what available flu strains are out. And in the years 2003 to 2004, the risk was 1 febrile seizure per 70,000 vaccinations. In 2010, it was high, 1 febrile seizure per 300 vaccinations. But with the current formulation, there's no increased risk. If you give the flu vaccine together with the PCV13, there's a 5-fold increased risk of febrile seizure compared to having the vaccines separately. So what are the outcomes of vaccine-proximate febrile seizures? Most febrile seizures are simple, as we said, the vaccine-proximate febrile seizures were not found to be different in seizure severity to febrile seizures of other etiologies. And there's no difference between children whose febrile seizures were associated with MMR or DTP vaccinations compared with the children whose febrile seizures occurred spontaneously. We'll look at vaccine-proximate afebrile seizures and status epilepticus. A retrospective study in Germany from 2006 to 2008 identified over 200 seizures following vaccination, of which 8% were status epilepticus and 17.8% were afebrile seizures. Berkovich et al. Identified 11 out of 14 children whose whose first seizure was a vaccine-proximate seizure. And these 11 had SCNA1 associated Dravet syndrome. In 12 out of 40 children with Dravet, the first had this in another study. They had their first seizure within 2 days of DTP vaccination, and these were 5 of them were status epilepticus, and all these children had their seizures less than 12 months of age with a mean of 4.5 months. Children with Dravet are particularly susceptible to fever-induced seizures. 16 to 21% of them have their first seizure after immunization. And the incident rate ratio of parent-reported seizures is 2.3%, 5 to 12 days after the first MMR dose versus the control periods of 0 to 4 days and 13 to 42 days post-immunization. In a Dutch study carried over 20 years of 1,729 children with seizures following vaccination, 6 out of 15 SCNA1A associated Dravet syndrome cases presented with status epilepticus. So in the study looked at by Berkovich et al., the 14 patients, he looked at them to verify whether there was any vaccine encephalopathy. These 14 patients had their seizures within 72 hours of vaccination. 78% had mutations in the SCN1A gene. A diagnosis of a specific epilepsy syndrome was made in the other 3. So, as we know now, vaccination might trigger earlier onset of Dravet syndrome in children who, because of an SNA1 mutation, are destined to develop the disease. However, vaccination should not be withheld from children with SNA1 mutations, as no evidence is found that vaccinations before or after disease onset affect outcome. So how do we manage future vaccinations in children with proximate seizures or epilepsy? So these are the recommendations that came out from an Australian journal in October of last year. So looking at simple febrile seizures, if these are, there's a documented fever without evidence of CNS infection, no recurrence within 24 hours, and no post-ictal pathology, as with febrile seizures in the general population, no investigations are required. And we continue vaccination in the usual setting in a general pediatric practice or a community clinic. If it's a complex febrile seizure, we exclude other causes such as electrolyte imbalances, CNS infection, and EEG is ordered, as well as CNS imaging, particularly if there's focality. And if there's no other cause found, we continue also the vaccination in the usual setting as before. However, if the seizure is afebrile, then whether it's generalized or focal in the absence of a fever, we exclude other causes, do an EEG, do CNS imaging, and may refer to a specialist immunization clinic for review and vaccination under medical supervision. If it's a status of epilepticus, a seizure lasting more than 30 minutes or multiple seizures over a 30-minute period with no normal level of consciousness in between, particularly if below the age of 1 year, then it's better, or the advice is to do genetic workup with an epilepsy panel to verify whether the child has an underlying epileptic encephalopathy, and to refer to an immunization clinic, and probably admit the child for vaccination using a vaccination protocol. So this is a protocol that was proposed, that children be admitted prior to giving inactivated vaccines, which is where you have a higher risk of seizures, and they remain for at least 48 hours after vaccination. The discharge from hospital can be considered after 48 hours, or if the child has been afebrile for 12 hours, you continue your maintenance anti-epileptic medication as usual. You prescribe a benzodiazepine. Whether you want to put an intravenous line or not is up to you, but at least PRN benzos are available. And but most important is the prophylactic medications that should be started 1 hour prior to immunization, and then regularly for 48 hours or longer if the child is still febrile. So this is paracetamol 20 milligrams per kilo as first dose, followed by 15 milligrams per kg every 6 hours, and clonazepam by 0.01 milligram per kg every 8 hours. And you would manage any seizure that occurs within hospital, just as you would with any epilepsy protocol, brief seizures. So you would, any seizure occurring, you would give you midazolam or lorazepam at the onset of a seizure. A status should be managed according to your hospital guidelines. So in 2013, the Italian League Against Epilepsy published guidelines on vaccination and epilepsy after reviewing evidence from published literature, and questioned whether vaccinations can cause febrile or non-febrile convulsions, whether the vaccine-related febrile seizures are different from common febrile seizures, whether vaccine-related febrile or febrile seizures would be likely to progress to epilepsy earlier than it would have occurred naturally, and whether some relationship existed between vaccinations and specific epileptic syndromes. And we just reviewed the literature there. They did the same. They reviewed different studies and scientific data from the Medline and Cochrane library. So in reviewing febrile seizures, they found that some vaccinations, and particularly DTP, can cause fever with possible febrile seizures. the rate, similar to what we found in our literature review, the rate of febrile seizures is similar in children with and without a personal history of febrile seizures. Vaccine-induced febrile seizures are no more frequent than febrile seizures with any cause of fever, and the risk of non-febrile seizures following vaccine-induced febrile seizures is not higher than in children who have not shown vaccine-induced febrile seizures. So they came up with the recommendations that vaccinations should be performed without contraindication in children with previous febrile seizures with a class evidence of 3 and a strength of recommendation A. The second recommendation regarding febrile seizures is that the occurrence of febrile seizures during vaccination should not discourage parents from further vaccinating their children. So the literature review on idiopathic and symptomatic epilepsy revealed that vaccinations did not cause afebrile seizures for epilepsy. There was no correlation between vaccinations and any specific epileptic syndrome, nor was there any higher risk of adverse events after vaccination in either children with idiopathic or symptomatic epilepsy. So the recommendation was that vaccinations should be performed without contraindication in children with both idiopathic or symptomatic epilepsy. And the risk of epilepsy, again, should not discourage parents from vaccinating their children. With regards to epileptic encephalopathy and vaccinations, no pathological correlation was found to exist between vaccinations and epileptic encephalopathies with onset in the first year of life, such as Barre and West. There is, however, that the vaccination might trigger earlier onset of these symptoms, and the vaccination was not associated with an increased risk of encephalopathy after vaccination. The recommendations were that vaccination should be performed without contraindication in children with epileptic encephalopathies such as Barre or West, with a class of evidence 3 strength of recommendation A, and that the possible risk of triggering an epileptic encephalopathy should not discourage parents from vaccinating their children, again with the same class of evidence and strength of recommendation. An article published in 2018 looked at the risk of seizures after immunization in children with epilepsy, performing a risk interval analysis. They did a retrospective study of children less than 7 years of age in Nova Scotia, Canada, from 2010 to 2014, and studied the risk of seizures after routine immunization in children with pre-existing epilepsy. And a risk interval analysis was used to estimate the relative risk of seizures during the risk periods of 0 to 14, 0 to 2, and 5 to 14 days post-vaccination versus a control period of 21 to 83 days post-vaccination. And so there were 302 eligible subjects, 166 consented, 147 immunization records were reviewed, and 80 subjects were eligible for the study because their one of the criteria was that these had immunization administered between the date of diagnosis and the 7th birthday. So there were 161 immunization events, which were visits for immunization among the 80 subjects who received their vaccines between their epilepsy diagnosis and their 7th birthday. And inactivated vaccines were administered at nearly all immunization visits, either alone or with live vaccines. And okay, so the risk of medically attended seizure was not increased. The medically attended seizure is any seizure that was brought to the attention of the medical services, whether this was a phone call to the office, a visit to the office, or a presentation to the emergency department. So there was the relative risk in days 0 to 14 after any vaccine was 1.1, with a 95 confidence level of 0.5 to 2.8. 0 to 2 days after inactivated vaccines was 0.9, and this was versus 21 to 83 days post immunization. And no seizures occurred 4 to 14 days after live vaccines. And this is the table which shows these here. So you quite a low risk of seizures within the risk periods versus the control period. This study also found that there may be under-immunization of children with epilepsy. Only 17% of children with immunization records had received the influenza vaccine, which is recommended annually for all children above the age of 6 months, particularly those with chronic illnesses such as epilepsy. And 14% of children had no recorded immunization events between the ages of 4 to 7 years. So the study concluded that children with epilepsy do not appear to be at increased risk of medically attended seizures following immunization, and suggesting that immunization is safe in children with epilepsy, with the benefits outweighing the risk. Here in Saudi Arabia, when we come to COVID vaccine, our vaccine campaign was unrolled in December 17th to vaccine the high-risk age groups and health personnel. The impact that COVID has worldwide on epilepsy is mainly due to interruption of care and patients not being able to get their treatment on time, being in lockdown away from hospitals and pharmacies. Of course, COVID can cause fever, and with any fever, the threshold for seizures can be increased. So I haven't, looking through the literature, I haven't found anything yet with regards to looking at side effects of COVID-19 that includes any seizures or increased events in epileptic patients. And the International League Against Epilepsy on their website tells us that there is no evidence to suggest that having epilepsy is specifically associated with a higher risk of side effects from a COVID-19 vaccination, and the risk of COVID infection and potential complications far outweighs the risk of side effects from a COVID-19 vaccine. And that, as with any febrile illness, paracetamol should be taken regularly for 48 hours after the vaccination, and this will minimize the risk for a breakthrough seizure. So in conclusion, vaccinating children at the recommended age prevents febrile seizures by protecting against these childhood illnesses. Children presenting with vaccine-proximate status epilepticus or afebrile seizure should undergo genetic investigations to look for an underlying genetic epileptic encephalopathy. Children with vaccine-proximate status should be referred to a controlled setting for their future immunization, so as not to trigger another status with possible complications and admission to the pediatric ICU. And in all instances, in all patients with epilepsy, further vaccination and full vaccination should be prioritized and is the goal. And thank you very much.
Yes, Dr. Lamia, thank you very much for your excellent overview and an extra presentation as usual. It looks rich from all aspects of vaccination, especially in pediatric age group. I'm sure there will be many questions, but we're going to save all the questions to the end. I encourage all audience to submit their questions to the chat bar through their Zoom, and then we're going to summarize all the questions after the lectures and the discussion. So now we're going to move to our next distinguished speakers, Dr. Anne Yee. She's a professor of medicine, senior scientist in the Neuroscience and Mental Health in Toronto Sick Kids Research Institute. She is leading in the field in MS and the neuroinflammation response. she has done many publications within the field of pediatric multiple sclerosis and the neuroinflammations. And she's going to talk about neuroinflammation's response to the vaccines related to neurological illnesses and particularly epilepsies and seizures. So welcome, Dr. Anne, for your turn in the webinar.
So much, Dr. Majid, for this surprise invitation and lovely webinar. I've already learned so much from the first talk, and I'd like to thank the Saudi Epilepsy Society also for coming up with the idea of this symposium and including me in it. I'm going to. My talk is really an adjunct to what Lamia started talking about in terms of the complications related to vaccines and questions that families might have related to vaccines. While this is an epilepsy forum, I'd like to talk about something that families in the press and the public are very concerned about, and that's in relation to neuroinflammatory disorders. Let me see if I can, okay, and these are my disclosures. So what I'm going to do is take a case-based approach to consider vaccine-associated issues within neurology, and specifically to talk about neurologic complications reported, and I say reported, to be related to vaccine use, to talk about the use of vaccines in neurologic patients on immunosuppressive medications, because this is something we're seeing more and more, and to introduce briefly recommendations for COVID vaccine in specific groups of neurologic patients. And so to start off with, I'm going to give you a case. And this is a case of a child that all of us in the audience and practicing neurology might run into. A 5-year-old child who presents with encephalopathy, sort of playing on the themes that we just heard about, and gait abnormalities. You do an examination and you see that the child has dropped reflexes, is unable to move the lower extremities, and is encephalopathic. And so, of course, you do an MRI scan of the brain, and this is what you see. And what you see here is swelling of the spinal cord with bright signal going along multiple segments, together with a multifocal picture within the brain showing cortical and subcortical involvement, and probably some white matter involvement too, maybe in the corpus callosum. So you look at this and you say, okay, well, I know what this is. I've seen this before. This looks like acute disseminated encephalomyelitis, some sort of an encephalitic presentation, probably post-infectious based on the age. But what the family is thinking is very different from what you're thinking. And they come to you and they say, I want to tell you that the MMR vaccine was given 1 month prior. Their worst fear is that the vaccine has caused the neurologic problems that they're seeing and will cause progressive neurologic disability. Again, playing on the themes and the discussion of the previous talk, where there has been a lot of sort of public talk about neurologic disability in relation to vaccines. So what do you say? Of course, you're armed with all of the information that Dr. Jad just gave in terms of seizures and degeneration and recommendations. But what evidence can you provide about vaccines and neurologic complications? And the parents are thinking, remember, this is what the parents are thinking. Do vaccines cause autism? Do they cause neurologic degeneration? And they are looking at the internet and whatever they can to try to explain their children's illness, but also to understand whether it was anything that they did, because there's an incredible sense of guilt that goes together with having a child that's experiencing an acute neurologic event. Trying to understand whether it was anything that they did that caused this problem. Well, you know this, right? You know that measles deaths are climbing and have climbed in response to vaccine hesitancy. And in fact, over 200,000 people died from measles in 2019 to the large outbreak that occurred, again, in relation to this issue of vaccine hesitancy. So in order to speak with families in a way to understand and to help them to understand vaccine a little bit better, I'm going to take you through a few, some of the evidence for what we know about vaccine as a trigger for neurologic disease. Because we all know that there are reports of neurological involvement in the press and concerns, which include seizures, which have been covered very well and thoroughly by Dr. Jad, but also autism and demyelinating conditions such as Guillain-Barre, acute disseminated encephalomyelitis, transverse myelitis. There's a lot of press about the COVID vaccine, actually, in relation to demyelinating conditions, MS, and relapses. And remember that vaccine hesitancy has led to outbreaks of once rare diseases such as measles. So what's the background of all of this? Why are people so worried? So I'm going to take you a little bit into the background very quickly, because the DTP vaccine saga is really one of the cores that has driven a lot of the legal and medical approaches to vaccine that we know today. As early as 1933, there were reports of possible neurologic complications related to the whole cell pertussis vaccine. And by 1974, there was a case report that looked at 50 cases of neurologic complications potentially related to the pertussis vaccine, which historically, at the same moment in North America, there was an upsurge in the ability to do personal injury lawsuits. Because of this, many families, because of the reports and because of lack of clear knowledge of the relationship of vaccine to neurologic complications, there were large payouts by vaccine companies to families in relation to the rise of these lawsuits. And in fact, every manufacturer of the DTP vaccine, except one, shut down their operation by 1984. And this became a public health crisis. And in response to this, the US government created the National Childhood Vaccine Act, supported by later the National Vaccine Injury Compensation Program, which would protect vaccine manufacturers and allow them to move forward on this very important mission. And at the same time came the publication of a large number of, not a large number, but several very good epidemiologic studies that asked the question very carefully and critically, as was pointed out in the previous talk, what is the relationship between especially neurologic complications, neurodegeneration, and vaccines? And of course, as you have seen and was so thoroughly covered, the association is really only with febrile convulsions. And in fact, this was with the whole cell pertussis vaccine. Okay. When you think about the issue of serious neurologic concerns in children after vaccine or anyone after vaccine, the issue is centered around either seizures and encephalopathy or demyelinating disorders. So this group asked the question of whether in Ireland, in a very large study in Ireland, whether there was an association between encephalopathy or any encephalopathic presentation or seizures or other what they identified as severe neurologic complications and the presentation and vaccine. And what they found was, as shown in the previous talk, is that the only serious complication that was found in relation to vaccine was complex febrile convulsions, and that occurred in the MMR vaccine. And this was covered in much more detail in the previous talk. But importantly, the issue of acute disseminated encephalomyelitis and other demyelinating disorders did not come to the forefront in this. However, has continued, and even in the 90s and the aughts, there have continued to be concerns about demyelinating conditions. And as recent, as I mentioned before, as recent as the emergence of the COVID vaccine with transverse myelitis and things like that, there was a question. And the questions of inflammatory or neuroinflammatory conditions in vaccine seems to always come to the forefront when a new vaccine comes out. So what is the evidence in relation to other neurologic manifestations? Let's start with autism, because we need to get that out of our systems, because that's probably the most frequent question that we receive from families. Did this, or is this going to cause my child to have a behavioral regression, a psychobehavioral regression that resembles autism? And just to give you a little history on this, and you guys, some people will remember this. Most people in the audience will remember this, and that's the retraction in 2010 of a paper that was written in 1998 by a gastroenterologist who was interested in the association or the relationship of inflammatory bowel disease and immunization, and happened to report on a group of children who happened to have inflammatory bowel disease and PDD type spectrum after, and reported, the authors reported that this was in fact something that occurred after immunization. As everyone in the audience knows, that this was retracted in 2010 after some very careful evaluation by a researcher who actually went back and looked at all of the cases that were presented and suggested that the data were fraudulently reported, and the Lancet actually went to the huge went the huge step of retracting this paper. Subsequent to this, and over the last 10 to 20 years, there have been multiple epidemiologic studies asking the very specific question of whether there's an association between MMR and autism due to these continually rising family fears, and none has been found. So it's important for all of us to know that families continue to be concerned about this, but also important to reassure families that multiple epidemiologic studies have been performed that do not find a link between autism and specifically the MMR vaccine or any other vaccine for that matter. What about other disorders? So I started this presentation with a picture of a child with acute disseminated encephalomyelitis. And the question that was in the parent's mind is not far off from the question that many families come to all of us with. So where does this all come from? And why is there so much talk about acute disseminated encephalomyelitis in relation to vaccines? Well, I'm going to remind you guys that vaccines have not always been as sophisticated as they are today, and very in the 80s, which to me is not that long ago, but was in medicine is really a lifetime ago. There were rabies vaccines that were produced that used neural tissue as part of their formulation, and what was found and became a cause of alarm was a large group of children in Thailand who had who developed encephalomyelitis or encephalitis, and the link was clearly made between the use of neural tissue and the development of acute disseminated encephalomyelitis. So in response to this, after the 80s, vaccines against rabies without brain neural tissue were developed, and since then there have been there continue to be people that report published case reports, but none of the cases have appeared to have a causal link rabies vaccine. So important. I'm aware that rabies is not a big issue in Saudi, but your families who are traveling and things like that might ask you questions about that. So the link between rabies vaccine and encephalomyelitis is no longer a concern. It is not a concern at present day. The other thing about acute disseminated encephalomyelitis and childhood inflammatory manifestations is that, and I'll talk to you about this in relation to MS as well, is that in the 90s, France had a massive campaign to vaccinate children with hepatitis B. And concomitant with the increase in vaccination was an increase in reports of neuroinflammatory conditions, and so the government actually went to the extreme measure of halting all hepatitis B vaccines to ask the question about the association between hepatitis B vaccine and demyelination. Now, you may think, oh, this is really old news, but I will tell you that on Monday of this week, someone asked me this very question about MS and about demyelination, a family, about MS and demyelination and its relation to the hepatitis B vaccine. And I want to let you know that there is ample and large evidence that there is no association between the administration of the hepatitis B vaccine and demyelination. And in fact, if you ask a larger question of acute disseminated encephalomyelitis, which is the case that I started out with, and vaccination, there's a very nice case control study that was published in the last couple of years that showed that there was no increase in acute disseminated encephalomyelitis for vaccination in relation to vaccination against any of the childhood vaccinations. So I think you can very clearly and confidently say to families that, yes, I believe in the recommendations to continue with vaccinations, and vaccinations have not been shown to associate with acute encephalitic demyelinating neuroinflammatory conditions of childhood. Okay. Let's go to Guillain-Barré because that's one that's discussed a lot. And again, with Guillain-Barré, rabies was one of the initial culprits that was where people became worried about an association of Guillain-Barré with vaccine. And again, the issue, just like with the acute disseminated encephalomyelitis issue, was the use of neural tissue. And since the development of vaccines that do not have neural tissue in them, and that was in the 80s, there have been no concerns about Guillain-Barré in relation to this. With regards to other vaccines where there have been specific questions of Guillain-Barré, the vaccines include the MMR, HPV, and meningococcal vaccines. And those have been studied very closely in large cohorts around the world and in Finland. And none of these studies have suggested an increased risk of Guillain-Barré with any of these. The influenza story is an interesting one because around the specific concern about Guillain-Barré with influenza revolves around the swine flu, and reports of swine flu vaccine and Guillain-Barré. In 2009, at the time of the H1N1 outbreak, the question arose again: is Guillain-Barré associated with a rise? Is a rise in Guillain-Barré associated with the administration of the H1N1 influenza vaccine? An initial report suggested that there was a higher likelihood than population risk for Guillain-Barré with the H1N1 vaccine, but and I really like the chart that Dr. Jad used to compare, what happens if you actually get the infection and what happens if you get the immunization. And it became very clear when looking at the evidence that while there may have been cases of Guillain-Barré that occurred after vaccine, the risk for getting Guillain-Barré when actually getting the infection, the H1N1 infection, was much higher if you had the infection rather than if you had Guillain-Barré, than if you had the vaccine. And so the bottom line here is that with Guillain-Barré, although there were early vaccine challenges with the rabies vaccine, and there may have been a link, at present there is all vaccines are considered to be safe and without particular increased risk for Guillain-Barré. Finally, with multiple sclerosis, I'll skip to the next slide because we've already talked a little bit about this, but just to let you know that the HBV concerns that were raised in the 90s have been refuted, and there are no associations with HPV vaccine. In multiple sclerosis, the issue of vaccine and vaccine causing multiple sclerosis have been present for many decades. And this has been evaluated carefully in multiple different cohorts. There are two studies I just want to highlight to you. And if, especially in speaking with families who want to know whether a vaccine triggered their loved ones' multiple sclerosis. The bottom line here is that this has been studied very carefully in several different populations, and there is no increased risk for MS after vaccine. And interestingly, in a more recent study in 2019, the suggestion in Varia and compared people with other autoimmune conditions with people with MS, with controls. The bottom line there was that people who had MS were more likely to have not had vaccines than the other groups, meaning if you had a vaccine, your risk for MS was lower, suggesting that the concept of a vaccine causing MS was likely not a truth. Okay, let's move on to the last set of cases, and this is really what to do in the immunosuppressed patient. And I'm going to present you with a 4-year-old child who, but it could be a 25-year-old person who's going on ocrelizumab or an immunosuppressant agent. Here, the treatment plan is to give rituximab, which is a B-cell suppressing agent, which suppresses antibody production. And the family would like to know whether immunizations should be given. When should this child be immunized, and what should be done about future immunizations? So for vaccination planning, I refer you, and I'll give my slides to the organizers, but I refer you to this very excellent outline of what to do in the immunocompromised child, and this really holds for any person who's immunocompromised. And the issue really is to know what to do when you're planning to give a medication, because timing is very important. If immunosuppression is planned, you should be giving all live and inactivated vaccines prior. Inactivated vaccines should be given at least 2 weeks prior to starting therapy, and live vaccines at least 4 weeks prior to starting therapy. If your immunosuppressive treatment is urgent, you can defer the vaccine until the immune system has recovered. However, if the risk of exposure, and I'm thinking of things like COVID right now, if the risk of exposure is very high, the inactivated vaccine can be given, but there may be a diminished response, okay? Patients on long-term treatment, the best thing to do is to give inactivated vaccines at the lowest anticipated dose of immunosuppression, and to hold or reduce therapy if you want to give a window to give the vaccine so you can get a good, a robust immune response. For steroids, live can be given 1 month after the DC of high-dose steroids, 3+ months after chemotherapy, and 6 months after treatment with B-cell therapies. If IVIG has been given, defer live vaccines for 3 to 11 months. But there should be no delay for inactivated vaccines. And remember also that that non-live vaccines are safe. Consider measuring pathogen-specific antibody concentrations if you really want to know if there's been a vaccine response. Do not give live attenuated vaccines, and think about VZV vaccination and disease history. Think about vaccinating prior to initiating the biologic. And going back to that issue about the influenza vaccine, it is strongly recommended to give the annual influenza vaccine. And then don't forget about indirect protection, and recommend that families and close contacts always get the routine and yearly influenza vaccine in addition to all routine vaccines. And don't forget about pets. Pets should be getting their routine vaccines. Okay, last case, and then I'll wrap up, and this will be really fast. Your MS patient is stable on an immunosuppressive agent, or your neurologic patient is stable on an immunosuppressive agent. What are the current recommendations for COVID vaccine? So what do you say? What are the current recommendations in this situation? So I've provided you with a few guidelines, links to a few guidelines, including that of the Association of British Neurologists, US guidelines, and then some specialty groups, including the MS Society of Canada. The National MS Society also has a very similar set of recommendations from the World Muscle Society. But I want to tell you that the bottom line, and this comes from the Association of British Neurologists, that appears in all of these, is that anyone at risk because of their age and other illnesses should have a COVID-19 vaccine. Now, this is a stronger statement than other neurologic societies have made. And in fact, the recommendation that I would say is that vaccine decision-making should be made in conjunction with the healthcare provider, but most societies are recommending vaccines. So if your patients come to you worried about this, please refer them to some of these statements, which for the most part, strongly support vaccine in almost all populations. Okay, so this is a summary of what I've just reviewed. Vaccine hesitation or hesitancy has led to major public health challenges that we're all aware of. And all evidence points to good safety and no increased risk of neurologic complications due to vaccines. They can be administered to patients who are on immunosuppressive medications with some caveats. And the COVID-19 vaccine is being recommended by many groups for specific patient groups in neurology. Thank you so much for your time. I'm happy to answer any questions after the next talk. Thank you.
Okay, thank you so much, Dr. Anne, for your excellent talk. It's very much interesting to see all the aspects of vaccines related to neurological illnesses, not only epilepsies, for neuroinflammations and MS. It's especially Guillain-Barre syndrome. It always comes up after all new vaccination. So as we mentioned before, we're going to save all the questions to the end of the webinar. Now we're going to introduce our next speaker, Dr. Izzeldin Akemi. He's the Director of Respiratory Disease and TB Prevention Program in the Saudi CDC, Saudi Center of Disease Prevention and Control, and he's going to talk about safety and monitoring of vaccines in general, and how is that related to the hot topic of vaccines, the COVID-19. So the podium is for Dr. Izzeldin. So Dr. Izzeldin, you have to unmute yourself.
Yeah. First, I would like to thank Saudi Epilepsy Society for their great webinar, and also I would like to thank you all for your attendance. I will talk today about safety in the community vaccination. The content will be about introduction, licensure, testing for safety and efficacy, emergency use authorization, continuous monitoring of the safety of vaccine, immunization safety, and surveillance system. And finally, I will show you the summary of this presentation. Okay. As we know, vaccination has been demonstrated to be one of the most effective interventions for preventing disease worldwide. The fact that vaccines are administered to the healthy people to prevent the disease have become rare, contribute to the concern about the vaccine safety. So, because of the devastating effects of the disease are no longer prominent, public attention is focused on the side effects of the vaccination, leading in some situation to reduce the vaccination rate and vaccination acceptance from the general population, and also lead to outbreak of the disease. Because the healthy people is not like the patient that have a symptom. The patient that have a symptom have urgent to take the medication, but the healthy people always asking, where is the disease? The disease is very rare. This is making more population concerned about the safety of the vaccine. So the general public has a low tolerance for any adverse event after vaccination, because it is giving, as we say, as giving to healthy people. So the vaccine are expected to have a higher standard of safety other than other medication. So how the vaccine developed and approved for safety and efficacy? First, first stage is a pre-licensure testing. The national regulatory authority like FDA in the United States or FDA in Saudi Arabia or any country, that vaccine is manufactured, tested it before licensing it. First, the vaccine is tested in the lab or in computer model. This is take about several years to make sure that the vaccine is safe and effective. Secondly, it is tested in the animal with immune system similar to the human to make sure there is no major side effects. Then a series of clinical trial is performed in the human. And the first thing, the researcher tests the vaccine in the adult. The phase 1, this is a 3 phase of clinical trial. The phase 1 is about 20 to 100 healthy volunteers are tested to determine mainly how is the vaccine safe or not safe and doesn't have any serious adverse effects. The second phase is several hundred volunteers, maybe about even can be 1,000, are tested to determine the commonest short-term side effects, whether the size and also the dose of the vaccine that can be tolerated by the patient. Phase 3, 100 or 1,000 of volunteers are tested. Usually they are the patient, the people who have the disease, are tested to determine whether the people who receive the vaccine are similar to those who don't, whether the vaccine is safe and effective. And usually this phase included a double-blind RCT, and this RCT can use a placebo. Once the vaccine has been determined to be safe and effective, the regulatory authority like FDA grant a license to allow sale and distribution of this drug. This is a summary for the 3 phases. So the phase 1 on healthy volunteer, it is to answer this following question: is this vaccine safe? Does the vaccine seem to work? Are there any serious side effects? And how is the size of the dose? Then the phase 2, more the large sample size. What are the most common short-term side effects? And the final phase, which is a complete double-blind study, hundreds of thousands of volunteers to answer: is the vaccine safe and is effective? And what is the most common side effects? Then the post-marketing stage, which are phase 4, known as post-marketing, involves surveillance of the vaccine for safety. And it is a continuous to know any side effects that not have been determined during those 3 phases. So it is for detecting any rare or long-term adverse effects. Usually, the National Regulatory Authority licenses the vaccine only if it is safe and effective, and also if the benefit are more than the risk. Then the next step, it will be the manufacture of the vaccines. Vaccines are then made in batch. It is called lots. Manufacturer must test all lots to make sure they are safe, pure, and also potent. Every lot of vaccine must be tested and double-checked for safety, potency, and purity to assure the uniformity of every dose of vaccine given. Now we'll talk about the usual phases of the vaccine, but now we will talk about an exceptional called emergency use authorization. This is emergency use of authorization allow the FDA to facilitate the availability and an approved use of medical countermeasure needed to prepare for and respond to any emergency like chemical emergency or biological emergency. The most recent example of this are COVID-19, and the product must have a criteria the disease must have a criteria to be engaged in this emergency authorization. Criteria for issuance is need to be serious or life-threatening disease or condition, evidence of effectiveness, and risk-benefit analysis. The benefit will be more than risk, and there is no alternative. And also, the category of product even is not approved at all, or it is approved for another disease, but we need it for a new disease. So, as we said, the most recent example are COVID-19. We can see that the vaccine is rapidly developed in just a short time, and also there is some medication that was not approved maybe for malaria, like chloroquine, approved also for COVID-19. Even it was now that approved. This drug is not effective for treating COVID-19. So before we complete a large RCT, this vaccine can be approved because of using the emergency use authorization. So for vaccine, for that there is adequate manufacturing information, issuing that may be appropriate once the study has demonstrated the vaccine is safe and effective. Okay, then we will move to the continuous monitoring of the vaccine. The continuous monitoring of the vaccine usually by many authorities like European Medicines Agency and also Food and Drug Administration in USA or even in Saudi Arabia, and WHO globally to monitor the safety of vaccine after their introduction. The purpose of monitoring is to detect the adverse event and to evaluate the possible side effects and to ensure any risk associated with vaccine are identified. Mostly, this continuous monitoring is in the phase 4, which is as I said, the post-marketing phase. And based on this monitoring, some drug or some vaccine can be withdrawn, or some vaccine recommendation may be changed according to this side effects. Vaccine adverse event information management system is also an example of this continuous monitoring. It is also used in United States, which is a huge network to report and to receive a reporting from all the states about any adverse event of the vaccine. So now we'll move to the immunization safety surveillance system. This surveillance system could be a passive surveillance, or it could be an active surveillance, or it could be ad hoc studies. The passive surveillance means reporting of all spontaneous adverse event after vaccination. It is a main strength, and it is early detection of the previously undetected serious adverse event. But it is mainly have a many limitation, like underreporting, like incomplete also reporting. But the active surveillance is used primarily to characterize the rate of adverse event, a risk factor. And countries may conduct active surveillance for only a selected adverse event at selected institution, or in the community, like by doing a cohort event monitoring study. Also, another method could be ad hoc studies, in that the epidemiological studies are conducted to extend the specific aspect of the vaccination safety surveillance, such as testing hypothesis and causality for any vaccination, like what happened in the association between the MMR and autism. Many studies prove there is no association between autism or MMR by doing this ad hoc studies. Role of clinician in vaccine safety. So not only the authorities or organizations that have a rule to make sure that the vaccine is safe, but also we are, as a clinician, need to make sure or to administer the vaccine safely. And this is really doing by a good storage of the vaccination, identification of contraindication, and providing health education for the patient. Also, the patient should inform or motivated to receive the vaccine and educated by receiving a clear fact. The person delivering the vaccine should then screen and reporting also for any side effects. So the question is, when to vaccinate safely? National standard for pediatric vaccination include a description of valid contraindication to vaccination and precaution to be taken. As Dr. Lamia and Dr. Ann talk about this contraindication and precaution from neurological diseases. So this contraindication need to be known to not give the vaccine, and this is maybe lead to serious side effects or even to a death. The people who administer vaccine should screen patient for contraindication and to take a precaution. So what is the contraindication? It is a condition in a recipient that increase the risk for a serious adverse reaction, could or even lead to death, to vaccination, and if there any contraindication, the vaccinated the vaccine not to be administered for the patient. For example, MMR vaccine should not be administered to severely immunocompromised person. Precaution is a condition in that recipient that may increase the risk for a serious adverse reaction and may cause diagnostic confusion or may compromise the ability of the vaccine to produce immunity. and the presence of moderate or severe acute illness with or without fever is a precaution in general for all the vaccine. So we talk about the contraindication should be known for the physician before giving any vaccine, and also the contraindication to prevent any serious adverse event. Now we will talk in Saudi Arabia, the role of the Ministry of Health and Safety. They are providing the vaccine supply to the community and monitor the vaccine cold chain, which is important, and health education program and active and passive surveillance by reporting any adverse side effects of the vaccine. And also the Saudi FDA, which also make a continuous monitoring for vaccine during the post-marketing, and also withdrawal of unauthorized or any unsafe vaccination or product, and also receive a report from MOH and even from the community. Then the Saudi CDC have a role in supervising the other organization and also issuing a guideline and recommendation for vaccination, and also conducting of a vaccine research. So in summary, we can say that the vaccine is very safe, and just it is a collaboration of the organization and also the manufacturers, and also the clinician have a role in safety, and also health education is considered an important issue in delivering and reassuring the population about the safety of the vaccine and to increase the coverage rate of the vaccination. This is my reference. Thank you.
Okay, so thank you very much, Dr. Izzeddin, for your excellent talk and your summary for the guidelines and safety and for vaccine monitoring. So thank you for all the speakers for your input. So now we'll have questions and discussions. We received so many questions and comments, so I'm going to start with a few questions. So for Dr. Lamia, there was some concern about Dravet and cautious with the specific epilepsy encephalopathies. I know that there is the pediatric now is not indicated in vaccines for COVID, but there were many questions asking about the age limit for COVID-19 and why the pediatric group are not really included. So Dr. Lamia, you have to unmute yourself, please.
I think most of the guidelines at this point are because of the availability of the vaccine, rather than looking at specific age groups. So the availability, they're rolling out the vaccine probably to high-risk groups to begin with, old age and diseased individuals. So I don't think there's a absolute contraindication for COVID that I know of. Children are at lower risk for serious COVID disease, but I think this is not mainly an administrative point for ministries of health that they would like to, particularly in high-risk groups, give out the vaccine. I don't know if anybody else has any other input.
Yeah, it hasn't actually, all of the vaccines. So the issue is around approval as well of use of the vaccines in the younger population, at least in North American settings. And so, so that's really where we are with our vaccines now, that it's all related to approval and who it's been studied in.
Okay, here is a very interesting questions. Maybe Dr. Lamia or Dr. Ann can comment on these questions. For somebody with autoimmune epilepsy, like for example, the autoimmune epilepsy, like various autoimmune, whether it's primary or secondary autoimmune conditions, is there a specific concern with mRNA COVID vaccine?
Do you want me to address that? I'm happy to address it.
Yeah, sure, go ahead.
Yeah. So there are no specific concerns related to any of the vaccines at present for people with autoimmune diseases, including diseases that autoimmune epilepsy, MS, and other things. So there are no present concerns, and in fact, the vaccines, the mRNA vaccines have been administered in trials and in public now to a great number of people, and it does not seem to have resulted in a higher number of autoimmune events. And COVID itself, looking at autoimmunity and COVID and even people on immunosuppression, there's not a large signal there that we can see. And the Ministry of Health can probably comment on that as well.
Sure. So I don't know, Dr. Izzeddin, if you have any comment about that.
No, I agree with Dr. Ann. Really, this is what she said about the vaccine.
Okay, Dr. Izzeddin, there is one interesting comment was sent. There's one comment about somebody who reviewed the original Pfizer's study for safety for the vaccine COVID-19, and mentioned that the study, most of the people were included in the study were in the middle age group, like not at high risk for contagious for contracting the COVID-19. Any comment about that? Whether it's really can change your from monitoring or safety perspectives for vaccines?
I think the problem in the study of on the vaccine from Pfizer, they engaged really the adult population, but they have a chronic disease, but also they have also a comparable group. They didn't receive the vaccine, and also the group who received the vaccine showed the vaccine is more effective. And even always, any trial need to engage only the adult. They cannot like engage the pregnant or children, because they may have any serious side effects or any adverse event. So I think this is even mentioned that the COVID-19 vaccine cannot be given to the pregnant, even to the people. It is not given even to the children based on this study. But for adults, it should be given, even for the people who have a chronic disease, because the having a COVID disease with the people who have a history of chronic disease, this is are more serious than not getting the vaccine, because the vaccine will prevent maybe 95%. And this is better than, even if the vaccine have any side effects, this is lower than having a COVID disease with a chronic disease. So I encourage him to take the vaccine, even if the sample size is not include all the diseases as he mentioned.
Yeah, I was looking to the WHO website just a while ago, and there was the Global Advisory Committee on Vaccine Safety. It's a subcommittee, they meet regularly. There was a meeting late January regarding more number of deaths for frail old people. And I think their final comment, there are no associations between the vaccine itself and their death. Okay, here's other questions. What about the chemotherapy and safe to take mRNA COVID vaccine? I think maybe Dr. Ann, she just mentioned something about.
Yeah, so that's directed at me. So there are can you hear me? Is that okay? Can you hear me? Yeah.
Yeah.
The current recommendations with almost all societies is a yes with the with using the COVID vaccine. You know, as our representative from the Ministry of Health has asserted, you know, even if it hasn't been tested in that particular population, the likelihood is that getting COVID is worse than not than getting the vaccine. And so the recommendation in almost all groups is to move forward. You know, as there are no live attenuated vaccines that are being tested right now for COVID, I would think that any of the vaccines, based on our previous knowledge, are okay. But the caveat is that this is the first time of using an mRNA vaccine, and so we don't know that much, but it appears to be relatively safe.
Okay, thank you. Another question is maybe for Dr. Lamia. Any specific precautions or concern regarding taking vaccines for patients with epilepsies? And maybe here we're talking about adult patients with epilepsies. They're considering taking COVID-19.
As mentioned by the International League Against Epilepsy, actually the advice is to go ahead and take the COVID-19 vaccine, as again, getting COVID is worse than being, unvaccinated. Okay, so you may get a fever, you may get a breakthrough seizure, but that can be dealt with as with any intercurrent illness that causes a breakthrough seizure. But getting COVID-19 is worse.
Okay. So epilepsy is not contraindicated to getting vaccines?
No, at all.
Yeah, so that's a big question.
There's actually been a study in the British Medical Journal which alludes to that COVID-19 patients may have a worse outcome than others. They're grouped into, they're not looked at specifically, they're grouped into other patients with chronic diseases. But it does allude to that being one of the chronic illnesses, having the vaccine is better than being concerned about any side effects. Should they come out in studies? Those so far we haven't seen any, or none has been reported so far.
Okay, here is a very interesting questions as well. Does COVID vaccine enter blood-brain barrier? If yes, can this induce possible cerebral side effect?
Did you want me to take that one, or do you want the Ministry of Health to take that one?
Well, anyone, maybe you can start off, then we can get the comment.
Yeah. So there's no information that COVID-19 crosses the COVID-19 vaccine crosses the blood-brain barrier. And if you look at side effect profiles of some of the early vaccines, even those reported cases of transverse myelitis, and the first, if people recall, the trial that was halted briefly for transverse myelitis was restarted because it turned out that the patient actually had multiple sclerosis. So there does not appear to be a signal with regards to encephalopathies. So the suggestion would be it probably, the vaccines that have been tested probably don't cross the blood-brain barrier. So that would be my response.
Okay, thank you. There is another question about the mechanism of seizures that are triggered by vaccines, whether it's related to fever mainly or for something else. So that was the second part of the questions. Maybe Dr. Lamia can comment about that.
So definitely with the seizures related to fever, it's in children or individuals with sensitivity to fever, that's related to the actual fever itself. We know in febrile seizures, not only does the fever cause, I mean, sometimes children have the fever after the seizure, despite having an intercurrent illness that does cause fever. It's due to circulating interleukins sometimes that causes the actual seizure. So no. So what was the second part of the question?
Yeah. So the seizure triggered by fever, or there are other mechanisms?
Certainly, in febrile seizures, most of them are due to fever.
Yeah. Okay. So there is a comment. We just heard about the study of combining different type of vaccines, the mRNA based, with other vaccines to be delivered to the same person. Does this increase potential side effect? It's very interesting for me to hear this.
Anyway, it certainly does give rise to probably better immunity, because you're giving different aspects of the different antigens related to the virus. So the suggestion or theory of better immunity to the virus is there. But of course, if you're giving two different components and each one of them has its own side effect, then you'd have a combination of side effects. But again, you wouldn't know that unless you studied that. So we can theorize, but we wouldn't know till you actually vaccinated these people with these two different vaccinations and looked at what actually happens retrospectively.
Yeah, I agree with you. There are many things which unknown for us now to reach the final conclusions. I was reading through this Oxford vaccines, which was in hold for sometimes a few months ago. There was a case where it was warranted a look back for the safety of vaccines, and I think there was a case of transverse myelitis was developed. And when they looked into the cases itself, it was in the control group, so the group who did not receive the vaccines to begin with. Mm-hmm. So they opened the study and they looked back to the people who get the randomization, and then after that they get the permission to continue. So it's, to me, there are many reasons to stop and blame vaccines. I mean, maybe part of the human nature to stop and blame something instead of just looking forward. Vaccines were easy target for many years to be blamed for autisms and epilepsies, and certainly Guillain-Barre syndrome was one of the main diseases were blamed for many things. So maybe Dr. Anne has any comment about that, or Dr. Lamia.
So I just think that gives you more confidence in the way that these vaccines are developed. If they stopped the vaccine or the randomization process or the double-blinded process just to see and verify whether it was in the vaccinated group or not. So that just gives you more confidence that people are not in a hurry. As you hear with these conspiracy theories, that people are in a hurry just to provide any quick answer to the public and not really look into people's well-being without their health being in mind. Yes. So I think this just gives you more confidence in these trials.
I agree. I also think that it's important to note all of the progress that's been made in the last 20 to 30 years since the first descriptions querying neurologic complications, which seem to drive the popular sentiment of vaccine-related problems. Certainly, there have been a lot of problems in the past, and I think the important thing that, when counseling families and dealing with this with families is to sort of talk to them about history and say that was the past and this is why we do things this way now, and to recognize why people are worried, because those reports, some of those things are real, like rabies was probably real. But it doesn't mean that the complications, that the discussion now should be based on the past experiences.
Yeah, so yeah, this is actually lead to one of the comments was sent by the audience and how to convince parents to take vaccines.
Yeah, that's a really tough one. I think both of us can. Do you want, Lamia, do you want to take that one? Or?
So, of course, I get a lot of questions from families because they get vaccinated at different centers from our center. They get vaccinated at a primary healthcare center, and they actually tell them, please give us a note that we can go ahead with vaccination. And I usually tell them, go ahead with vaccination. There's no contraindication. They may get a fever just as any other child can get a fever, and you may have a breakthrough seizure. You would probably want to pre-medicate with paracetamol like 2 hours before you get the vaccine, and then 48 hours afterwards. So we used to get, we still do, I still do almost every month, get a request for a note to give to the primary health facility on whether a patient can have vaccines or not. And usually these are children who are with cerebral palsy or an epileptic encephalopathy. Now, guidelines before were, and probably to some extent maybe true now, were that if you have a child who's probably encephalopathic with seizures, that you would want to wait till you get the diagnosis and stabilize this child probably on anti-seizure medications before you set them out to immunize them. But definitely they should have all the vaccines that are recommended by the Ministry of Health within that their region. Of course, absolute contraindications are usually allergies. So they're not related to the seizure or to a patient having an epileptic encephalopathy or an epilepsy. Again, as mentioned in my first lecture, is that once you have a child with encephalopathy or one who's delayed and has his first seizure onset, you should do an epilepsy panel to figure out whether they do have a gene predisposing them to an encephalopathy or an epileptic encephalopathy.
Yeah, and I think I could add to that in terms of the approach to the families, because I think that there are several things. One is that primary care physicians often have questions in relation to whether it's safe to vaccinate children, and it is our job to sort of educate about what's safe, which it's usually safe. But the other part is getting into the heads of families to understand where their fears are coming from, because I think one of the things that happens is that we are very confident in our facts, and we've read a lot, and but we don't always understand where the parents' fears are coming from. And so addressing that within the clinic, meaning saying, okay, what is worrying you, and how can I help you through that? I think goes a long way to helping to convince families that it's the appropriate thing to vaccinate. And if it's that they've read certain things, that you can actually share information that refutes that, or let them know that you're listening. I think it actually really goes a long way to convincing families it's the right thing. And in the end, it's probably different in North America than Saudi. But in North America, sometimes families, no matter what you do, they make their own decisions. And it's very much out of our control.
Yes, I agree. And certainly families that may have, a concern that's not, that you're not thinking of, and you have to address it. One thing that's different here in Saudi Arabia is that families are sort of forced to have the vaccine. In a way, you can't have your permanent birth certificate unless you've had all your vaccinations, and a child is not allowed to enter primary school without having his immunizations done, his vaccine card to show for it. So that's one way of totally vaccinating your community, but again, you take away parental decision and parental control there.
Okay, excellent. Here is another question for Dr. Izzeddin. Is there a process for any healthcare provider to report any side effect for COVID-19 he has seen on a patient or any patient?
Yeah, there is a link from the MOH and also a link from Saudi FDA. They have a link to make a reporting of any sign of any symptom, even to the public, not only the health practitioner.
Okay.
For any side effects.
Okay, and do you know of any reported side effects so far here in Saudi Arabia?
No, still the common side effects, the fatigue, fever, and it just mild and the pain at the site of injection. There is no serious side effects until now.
Okay, good. There's another comment here. Is the COVID-19 yearly vaccines, or for an individual on immunosuppressive medications will have to take it more frequently?
I don't know if you would like to take that.
Yeah, maybe Dr. Ann.
Yeah, in terms of the immunosuppressive agents, we really don't know what the effect of COVID vaccine is going to be on the titers, and so what I'm hoping happens in the future are studies that evaluate titer-specific response, so immune response to vaccine in treated patients, because that's the only way we're going to learn. And there's going to be variability within this patient population anyway. So if it turns out that I would think, because there's so much attention to this, if it turns out that there's a less robust immune response, I imagine that the folks that are in immunization, meaning the public health and infectious diseases folks, will make a plan as to how to provide boosters.
Okay.
It's unknown right now.
Okay. And how long the immunity will last after the COVID vaccine? Is it like a flu vaccine? I don't know. I think there's many unknown again, but maybe Dr.
I don't think anybody knows. I don't think anybody knows. I mean, if you compare it to the flu vaccine can be given twice yearly. It is produced twice yearly with the most prevalent flu strains, and the immunity is anything for 3 to 6 months. And I mean, it is updated each season. It's not the same strains that are given. So with the flu vaccine, with the COVID vaccine, already you're getting different strains. How would that translate into future vaccines? We don't know. I don't think anybody knows.
Yeah, and there is another comment. Any protocol to prevent post-COVID-19 seizure? I'm not sure if we have any reported seizure related to the vaccine so far here.
So far, I mean, I haven't seen any reports. I have searched for reports on seizures. I haven't seen, but again, like with any intercurrent, with any fever, if you should get fever with COVID-19 vaccination, that will lower your threshold for a breakthrough seizure, just as with any intercurrent illness or fever. That may perhaps.
Okay. So there are many other questions, but I think we're just going to pick the most relevant or most relevant to the general populations and for neurological illnesses and epilepsy. So if you have any comment for to open discussions for Dr. Lamia, Dr. Anne, or Dr. Izzeddin. Any comment about the COVID? I mean, for me, I think the COVID impact was worse than anything you can think about vaccine-related illnesses or side effects. You can see, I think, all healthcare provider has examples of delayed cases, delayed diagnosis, delayed treatment because of the COVID impact. And if you compare all of these to any side effect of the COVID vaccines, clearly the benefits outweigh the risk.
Yes, I agree with you. We've personally, we've seen patients that haven't been able to get their medications. We've had virtual clinics, but we've actually been able to DHL medications to families, and DHL, even at that point when we were in lockdown, even DHL controlled medication, which we couldn't do before. We DHL that to families, but still some families slipped through and weren't able, and so that they came up with breakthrough seizures and statuses. So certainly, and some of them were just quite, even after lockdown, were quite afraid to come to the hospital because of the they were afraid that they would get COVID-19. So it's disrupted their medication supply, their ability to meet with the physician, even though we're there and we're able to talk to them on the phone if needed, but still some didn't know of these facilities put in place or services put in place, and did fall through and were affected, of course, psychologically. They were affected too, being afraid, particularly families afraid of their disabled child with seizures, contracting COVID-19, and they would come to the clinic by themselves. You should see a mom or dad or both of them not wanting to bring the child to the hospital. So suddenly the disruption that it caused in their ability to access medical services, whether it was true or whether it was perceived, did affect them. And the vaccine so far is a better alternative, we think, in the medical community. But again, we have to, convince families and patients. Up till now, the COVID-19 vaccine isn't compulsory. So a lot of patients, don't have to get it, and some of them don't get it, and they are afraid of side effects or of myths that are circulating through social media.
Yeah, I'd be interested to see what happens in the next few months in terms of vaccine uptake within the population, because right now there's so much fear within the population, at least in North America, of getting COVID, that it may be a very different story with the COVID vaccine in comparison to these other vaccines. And that goes back to complacency and not having seen terrible things happen with the older vaccines. But, many people now have experienced both inconvenience in their lives, but also tragedy. And so it may very well be a turning point in terms of belief in vaccines and uptake of vaccines. We really don't know, but I would be surprised if people had the same attitude towards this vaccine as to other ones.
Okay, so Dr. Izzeddin, any final message for physicians and all the neurologist community?
I think any physician who need to educate the patient and also to resolve the barrier for the vaccination. This is very important. Even in COVID vaccine, the people are very afraid of getting the vaccine, and I think this is because the vaccine is developed in short time, and some people agree the vaccine is just the trial is just for 2 months long, so they don't know what will happen after 2 months. So I think the physician have or the clinician have a great role in educate the patient about the safety, about the benefit risk of the disease. Getting the COVID disease is more worse than taking the vaccine, even having any side effects. So my message is like every barrier and every misunderstanding about the vaccination.
And Dr. Lamia, any message for the neurologist community in Saudi Arabia?
With regards to COVID-19,
Yeah.
I guess the same message. Make sure your patients know about the availability of the COVID-19 vaccine, and it's there in the community, and that it's better to be vaccinated than not. We haven't seen side effects yet. Hopefully, and we don't anticipate. Again, time will tell us. We don't know. There's a lot of uncertainties, but again, taking the vaccine is a safer approach.
Sure. Dr. Anne, any final message for the community of neurologists here in Saudi Arabia?
No real final messages, except that that hopefully what we've been able to share today would be helpful to you in your daily practice and in talking to families about not only the COVID vaccine but various vaccines and the real safety at present time, because I think it's actually often neurologists don't think about it as their job to talk to families about vaccine, but it actually is a big job of ours, because a lot of it comes back to neurology and neurologic fear of neurologic side effects. So hopefully this will be helpful in your armamentarium of being able to support families in this time.
Thank you. Yeah, I think this is part of our job as physicians to share and expand knowledge about all aspects of medicine. So at the end, on behalf of the Saudi Epilepsy Societies, I would like to thank all of the distinguished speakers who shared their time, their knowledge, and their expertise within this hot topic here about vaccines. This is an outstanding international webinar concerning a very hot topic about the vaccine. Thank you all.